anybody be able to do that? So take some of the savings from the drugs and put it into pulmonary rehab. I mean, it's a no-brainer. So congratulations to you. But my next question is a bit harder. In relation to last week's episode about spread, how have you managed to actually spread that innovation across Wales? Because I'm sure it's incredibly hard. We know that.
Incredibly hard. And it takes a good deal of bravery from finance and operational management colleagues to come alongside clinical teams to do this. The one thing I would say that I've learned about this is that you can only scale this up if you come in behind it with policy change and with support from some of the bigger financial levers, for example. So it needs to go into organisational plans, because then you can start to take account of, well, what are the financial levers to make this happen? Do we incentivise it? Is it about allocating resource differently? Do we have a separate value pot of money that enables this kind of shift to occur? Otherwise, it's incredibly difficult.
Perhaps one of the things that I've learned from that approach is people often don't bring in the financial teams in the organisation early enough. You might think they're not part of the clinical decision-making process, but they are on an organisational level. So that was a white paper that we did years ago about making the financial case for improvement. It's really important. But then the bit that you're doing as well, Sally, linking into ICHOM, isn't it, is making sure if you've got that clear outcome data at the end, then all that investment and all that hard work is justified, and people can see that it's changed as well.
Yeah, absolutely. And I think certainly in my experience of working in healthcare organisations, there is not the scrutiny of even clinical outcomes actually on a rolling basis that you get with scrutiny of processes and finances within an organisation. So if you think about all of the data and so on that executive boards require to manage their organisation financially, they should have exactly the same data at their fingertips around clinical outcomes. So the challenge, I think, is to move things like clinical audit away from being an annual report to a rolling monthly interactive data set where we're constantly well, what are our outcomes? What does that tell us about unmet need in our population? And then how do we go about meeting that unmet need and prioritise that? And I'm sure that will be a big agenda for the ICSs in the integrated care systems in England, and it certainly has been for the health boards in Wales and elsewhere in the UK.
One might say that we need financial excellence rather than financial perfection as well.
The Oral Apothecary is sponsored by Jamie Hayes Executive Coaching and OneLessPill.com.
So, fascinating stuff. I think we could speak all day about this, actually. But we're going to need to move on. So, Sally, absolute pleasure to have you on, actually. I'm sure you've listened to some of the podcast episodes and you'll know what's coming. Perhaps first you could give us a desert island drug, which is something that evokes a very powerful memory for you.
Yeah, so I've had lots of fun thinking about how controversial I could be over this. And my desert island drug is amitriptyline.
Oh, yes. We've not had that.
And the reason that amitriptyline is my desert island drug relates to what I was saying earlier on, I suppose, around protocols and evidence and how there is still, in spite of all our scientific approach, a massive art to medicine. Amitriptyline gets a fair bit of bad press now. I'm waiting for it to be banned because of the cholinergic burden and, potential harms and so on. But the fact of the matter is it's such a jolly useful drug as well for so many of those ill-defined painful conditions, especially when combined with poor sleep. And, a lot of general practice is really messy. It's about trying to help people and trying to think, what tools have we got to relieve people's suffering, actually. And over the course of my career, amitriptyline has been one of those drugs that has been incredibly useful in inexplicable ways for quite a large number of people.
Absolute perfect choice. And when I do this sort of teaching and we do desert island drugs and dirty useless drugs, very often we have half the camp put it in DIDs and we have half the camp put it in duds. But I'm with you, it's definitely a did. And even 5 milligram works.
Can you spell it though?
No.
No.
I can pronounce it though.
It's an old drug as well, isn't it? I have memories of
225 milligram.
Well, it's one I can remember for various reasons, my sister having when I was very young, years ago. And I've always remembered it because it was unusual to see a drug like that. It was a Nafranil, was it? Is that right?
No, that was clomipramine, wasn't it?
No, it wasn't a Nafranil. Anyway, but it was amitriptyline. I remember seeing it years ago. So how old is it?
It was developed in the 1950s. I looked it up specially for you.
Oh,
there we go.
She's good. She's good.
She's very good. Right, well, that definitely goes in the Royal Apothecary formulary, so thank you much for that, Sally. Now, what about a career anthem then?
Well, the first thing that popped into my head was I Want to Break Free by Queen, but that's not my choice.
Love the video.
Yes.
And so, Sally, you do for our listeners that don't follow you on Twitter, you do share a lot on Twitter.
I do.
Your musical tastes and your dancing, your kitchen is often features as a stress reliever. I'm guessing as well from the day job and all the complexities that go with it. So it must be a hard choice.
I think you can normally tell a sort of day that Sally's had by the choice of song. And a Friday night, it's usually some sort of rock anthem, isn't it?
I didn't know we were going to have an aficionado on.
Oh, very much so.
Yes.
Very much so.
Come on then, you're going to have to impress me now.
Well, this was a really difficult choice because you're quite right. Music permeates every aspect of my life, and goodness, there's a song for every mood, isn't there, as you've probably noticed in my life. The fact of the matter is that my favourite music is heavy rock music, heavy metal. I absolutely love it. I had a massively misspent youth seeing lots of rock concerts, and I have latterly started going back to them again, and I am quite deaf as a result of that. So I thought, well, which rock anthem would I pick? Because it is my go-to thing. You know, if you in healthcare there are days where you just think, I don't want a soldier today. I just can't face it. And then, you've got to put your big girl pants on, get in the car and put on some rock music, and that sets me up for the day. And it's usually Iron Maiden. So I was going to pick an Iron Maiden track, but I just couldn't do it.
She's teasing us. She's teasing us.
My rock anthem is my second choice after Iron Maiden when I want to psych myself up, and it is Joan Jett and the Blackhearts. I love rock and roll because I sing it in my car at the top of my voice, and the challenge is to get the ow at the right point. And I get it wrong every time. But yeah, so Joan Jett, I love rock and roll.
Genius. Yeah, I thought you were going to come up with the same as Dr. Mark Porter then, because he picked heavy metal as well, didn't he?
I did see you make a Stones recommendation in the interview you gave the other day for the RCP magazine, is it? Commentary?
Yeah, I like, when I was a medical student in Cardiff, the song I would always put on the jukebox in the TAV was Sympathy for the Devil.
Oh,
wow.
So we really are talking to an aficionado. So I think we'll definitely accept Joan Jett. I love
That's
rock
a
and
great
roll.
song.
Classic song and a really, really good story.
Well, it brings us back after Cal and Lan, so it brings us back into...
Yeah, well,
more, yeah.
It takes all sorts, doesn't it? It's like licorice all sorts. The playlist is very, very, what's the right word? Eclectic.
I think the Spotify algorithm is struggling a bit now, though. When you've played all the songs and it has to pick the next one, I think it's struggling a bit.
Oh, we should just check that. Actually that isn't what Sally's picked. She's gone onto Spotify. She's seen what's on there, and Spotify's come up with the next choice. No, I'm joking. No, that's a great story. Okay, and the last one, which I think people find the hardest, and I think the longer we've been going, because we've had 23 episodes, it's going to get harder, I think, for people to choose a book for listeners that you would like to recommend.
The book I'm going to recommend is called Reckoning with Risk by Gert Gigerensa. Gert Gigerensa I met in 2015 and had the great pleasure of hearing him speak. He's a terrific speaker. He's a German psychologist, and Reckoning with Risk is a brilliantly accessible book around how to describe risk and uncertainty to patients, but in life in general as well. But I absolutely love it. It totally changed the way I thought about risk, and it's also a deeply reassuring book because the first chapter is all about uncertainty, and of course most of us as healthcare professionals are managing uncertainty on a daily basis, and it's quite uncomfortable for us, particularly in primary care where you've got ridiculous levels of uncertainty and undifferentiated illness constantly. So the first chapter on managing uncertainty and sitting with uncertainty is just brilliant, and it's packed full of excellent quotes from Gert himself, but also from others. It's very philosophical and I can't recommend it highly enough. It's fab.
I agree completely, Sally. I have 2 copies sitting on my shelf next to me. When I read it, I changed all my teaching based on it, and I just put in most of the scenarios that this was a long time ago now, and I changed the way that he brought it to an audience is fantastic. So that is a real one for our listeners.
Okay, Reckoning with Risk by Gert Gigerensa.
I'm ordering that on Amazon as we speak. That looks fantastic.
I am currently reading Jonathan Haidt, The Righteous Mind, which was recommended by Dave Slawson, and that is fascinating. It's quite heavy going at times, but I love the psychology angle, so I'm definitely going to have a look at that. So Reckoning with Risk.
The follow-up to his book was Reckoning with his Gut Feelings, I think, as well, isn't it? That was his next one, I think, Sally, as well. But Reckoning with Risk, that's it.
Well, seeing as we've been talking about heavy-duty things, apologies, if you like, for I picked today's micro-discussion topic, and it is a bit heavy-duty. It's in one of my favourite journals, which is Bmj Quality and Safety, and it's got a long title, but it is about bridging the feedback gap and a socio-technological approach to informing clinicians of patients' subsequent clinical course and outcomes. And to the nuts and bolts of it for the listener, clinicians need effective feedback on individual patient outcomes to help improve their future diagnosis and treatment management skills. And what this paper really does, and it is quite heavy going, I suppose, but it talks about the need for IT solutions. I know everybody thinks there's a solution for everything through IT, and there are logistical issues, but the way I think it captures it quite nicely is it talks about a patient and a clinician. And if I'm the first person to see them, let's say, and then they go on a journey, I'm the upstream clinician, and then they go on this continuum, and then they go downstream and are dealt with loads of other downstream clinicians. But unfortunately, me as the upstream clinician don't really get enough information, if any, about what happened to that patient after I first saw them to help me in the future make better decisions. And in a nutshell, it's saying that we've got to try and use the socio-technological way of using IT to be able to make that happen so that the feedback is coming without too much effort and admin, so that better clinicians are made through better decisions from what went before. In essence, that's what it says, doesn't it? So yes, it is a bit heavy, but Sally, do you have any views on it? Did you read it?
I did read it. It was quite heavy, Steve. Yes, it was. I had to do it in chunks because it was late at night when I read it. But yeah, I mean, understanding what happens to your patients after you've seen them, whether you have sent them on after a diagnosis or whether you have given them a treatment or some other intervention is really, really important, isn't it? And I suppose in general practice, we're probably luckier than most in that it's easier for us to get that type of feedback. Should we seek it? You know, I used to, when I was in clinical practice more than I am now, I used to keep a little watch list sometimes if I'd seen somebody I was unsure of or something potentially interesting. But of course, the ones that we really need to learn from are the ones, the sort of unknown unknowns, aren't they? The ones where you think you were fine and actually you weren't fine and you have a blind spot there. So how do you identify those? So that's quite an interesting one for me. I did feel, I've got to be honest, a little bit sceptical about the technical solution that they proposed because of coding accuracy and how can we be certain about the accuracy of the information being fed back, and I was also a little bit worried about how that would land if it was really bad, you know. I mean, if it's sort of really bad feedback, how is that going to be carried out? So I was very sold on the idea of how we make it better, less sold on their proposed technical solution, I suppose.
It's a bit like when they said about the Belfast problem of moving out of Europe, wasn't it? It said, we'll design something, but we haven't designed it yet.
The principals in the paper are fine. They were obviously enamoured with a technical solution. I'm much more in favour of a social solution, and when we've looked at this in the past. So I've done lots of work in the past about how can you improve learning from error. It's a similar situation with errors. People feed data into things like NRLS or Datex or other sort of reporting systems, and nothing ever comes back. So stuff is done in response to that data, but the person who made the report never knows. And what was really effective was we tried things like bringing, it was actually GPs and stuff together to sort of look at these reports, learn what happened, have a conversation about it and go away having learned something. So it was obviously a bit time consuming. It was a much more social approach to learning from error, and I wonder if that's what doesn't happen here, is that those downstream clinicians don't meet very often with the upstream clinicians, there's just no relationship there, is there? And we see that hospital doctors often moan about GPs and vice versa. They don't go for a curry like they used to talk about people. So there's not that social element. And so feedback's important, but I also think if that lack of feedback is down to the fact that we don't create those sort of social interactions in the way that we used to, perhaps.
It's those damned ABPI rules.
Yeah. But they're right though, aren't they? Come on, we're in 2021, and I'm not saying that the IT is not impossible to, I'm not saying that it's not going to be difficult. But if you think about it, when they talk